again to another installment of Holland Hospital's Physician Lecture Series. I can only begin to tell you how pleased I am to get a chance to spend some time with you this evening to break away from what we do every day and get a chance to come to the community with some insight, with some background, and potentially with some information that will serve you as you begin to try to navigate what will undoubtedly be in the next couple of years a very, very difficult healthcare system. So I'm very pleased to get a chance to break ground on a topic that is near and dear to my heart, and also near and dear to the team of people that I work with every day, because we live this topic every day. Figuring out where and how to get people who have unplanned and unscheduled illness to the right place at the right time so they can get the right care that they deserve. So we'll answer that question tonight, but I should let you know that this will not be the last time that you get a chance to hear about the topic. Part of the reason is that as we begin to face some of the realities that are part of the Affordable Care Act and healthcare reform, without question, communities, healthcare institutions, insurers, practitioners, and of course patients are going to face many of those new realities, and figuring out how to get top quality care for unplanned and unscheduled illness and injury to the right people at the right time, and being able to get it to a large community of people. There's no question that the number of people who are going to require these services is going to continue to grow, and especially to do that well in an era where we are seeing dwindling healthcare resources and the financial backing that will make that possible for most people, and also limited institutional capacity. I'll touch on a few facts tonight that let you know the status of both industries, urgent care and emergency department. And though we're very blessed to actually have a very top quality emergency department in this community, that is not the case and will not be the case in the future for a number of different communities. So I'm very pleased to be able to get a chance to bring this to you. And I think the only other thing that I want to share with you tonight before we move ahead is that it's my sincere hope that you begin to recognize the importance of a forum like this. One of the solutions that I see going forward for putting patients and people in a position so that they can make the right decisions to take care of themselves, they can make the right decisions for their families, is to have forums just like these, community outreach forums that let people gather the information that they need, learn the important skills that they're going to need to learn, and begin to develop some confidence in navigating a very difficult healthcare arena. And I'm also pleased to represent, and most of you here probably know that, not only the Department of Urgent Care Medicine, but clearly Holland Hospital continues to distinguish itself as a top 100 hospital, and kudos to this organization for its clinical excellence, its innovation, and its service to this community. But I'm also very pleased to say that the Departments of Urgent Care Medicine and Emergency Department continue to distinguish themselves as among the nation's finest. So for me, it is very, very fun to get a chance to come to you like this and to begin to share some things. I'm going to move forward. If I can get the audio visual to work here. There he is. There are some of you here who already think you know who that little guy is, and we'll get to him in just a minute. But before I move forward, I just wanted to offer a few thanks. An effort like this does not take place with other people behind the scenes who make a lot of this work. And just a few quick thank yous. Amy Morris and the team at Holland Hospital's Marketing and Communications Department, thank you so much for backing us up and making sure that the evening works. Ronnie Banks is in the back, who does this regularly, and her expertise on board tonight is certainly helpful. And Joe Kimmy is my audiovisual wingman tonight. I appreciate that, Joe. I'm pretty sure that you and the rest of the team could find plenty to do on a perfectly beautiful Michigan summer evening, but you've dedicated yourselves to backing me up tonight, and I will certainly make sure that your superiors are aware of it. How about that? So I appreciate your commitment there. I don't know if they told you when you registered, but there is an audience participation poll. Now this is getting interesting. People are waking up now. And hopefully if there's enough time, there's a quiz at the end. Did you hear about that when you registered? Fantastic. I love it. Now everybody's listening. I got it. But I think it's important that I get a feel for who I'm talking to. It helps me kind of tailor some of the message that we'll give you this evening. And so the questions are pretty benign. They aren't anything that you'd have to be worried about, but I certainly want to ask a few of them right off. Who is new here to this forum, Physician Lecture Series? Who's new to that? Okay, so there's a healthy population of folks here for the first time. So kudos to you tonight. I mean, my recommendation is come, and come often. There's a lot to learn, and as an ongoing program, the investment of an hour in your time, you may not realize it now, but it could pay dividends down the line. That could be remarkable. Good. Second question, since I know who's here for the first time, is there are some who I know in the audience are, but But who in the audience has healthcare background, either formally or currently right now? So a lot of folks, good. Well, that helps me because I get a chance to tailor this message to those of you who do and those of you who don't. That's going to be important. And the last question is who has been treated or evaluated and treated in either an urgent care center or an emergency department at any time? So that's the healthy majority of you. Well, now that I know a little bit about you, that's helpful. I will share a little bit about me. There is no formal introduction in terms of my background, and I like it that way. But as the slide might suggest to you, I started this medicine thing pretty early. And you may not know, but I think Ronnie picked up on it in the back. I was born and bred a Hoosier. I'm from Indiana. And I did my undergraduate training at Indiana University. And so what that means is that I didn't have the privilege of attending Hope College or Calvin College. And so in the minds of some of my colleagues, that means I trained abroad. That's what they think that means. But anyway, I did my undergraduate work there. I did my medical and clinical work at the College of Human Medicine at Michigan State, then in East Lansing. It has since been transplanted to Grand Rapids. And for those of you who know that, that is an absolute major boom for both the Lakeshore and West Michigan in terms of what it will mean for the medical sciences in the next 10 or so years. So more on that later. And I did my residency training, my specialty training in Grand Rapids, and have been pleased to be practicing at least in West Michigan for about 23 years now, and the last 3 years of which have been in the Holland Hospital system. So lastly, this little guy's here actually to remind me of one of the things just to make sure we touch on tonight. I don't know if you can tell from the angle that you're sitting, but I can certainly see it from here. But that diaper's pretty full. Okay, and my hope is this evening is that's how I get a chance to leave you. Not so much with a full diaper, but full of wisdom, full of some information that's going to be useful to you, and confident that you will be able to navigate a very, very complex healthcare system. And as for me, pretty simple. Public speaking is not one of the most fun things that I do, but when called upon, I'll certainly do that. And my very, very small agenda for myself this evening is to make sure that when I'm done, we've covered the information, and that my pants look nothing like his. So I think if we're all on the same page there, we can go ahead and move forward. So, but anyway, what you have before you is a snapshot of some of what we'll cover tonight. Learning objectives, understanding urgent care and the emergency department. What are they and what they are not? How to choose where to go when unplanned injury or illness develops. And that's going to be the take-home question tonight. And last, there are some major take-home points. We'll cover many of these as we go through the evening and go through the information. And that's probably where most of the quiz questions that I talked about are going to come from. So relax, I'm just kidding. I'm kidding. So anyway, and then if there is some time left, maybe some question and answer. So depending on how the evening unfolds, we'll do that. Okay? Learning objectives. What we like to do is accomplish these 4 things. We'll settle some of the confusion, the myths, and the misconceptions about the kind of care that's provided in urgent care settings and in the emergency department. B, we want to acquaint you with the important similarities and differences between those 2 venues. And part of that will allow you to do further research so that you can understand them more intimately on your own. That'll be important. Number 3, or C there, is to empower you to recognize and choose the proper venue when you or a family member is facing unplanned or unscheduled, unanticipated acute injury or illness. And 4th, we want to educate you regarding the benefits of getting the right care in the right place at the right time. Let's start first with an overview of urgent care in the emergency department. Though there are a majority of you here who've experienced the 2, I think it's important to understand where they've come from, what they are as industries today, and that'll help you in your decision making if you're faced with having to find yourself in one capacity or the other in the near future. Let's start with urgent care medicine. The definition that you have in front of you is actually a synopsis of definitions that have been offered by the 2 foremost trade organizations and professional organizations in urgent care medicine. That's the American Academy of Urgent Care Medicine and the Urgent Care Association of America. They are the flagship organizations that are really moving forward with setting the industry up and making sure that it gets to do all that it should do. And the bullet points there are pretty straightforward, but I'll just read for you quickly in the interest of time what they've come together and agreed upon as a definition for urgent care medicine. It is the provision of acute, ambulatory, unscheduled healthcare services for conditions and injuries that require immediate attention but are not likely to progress to further disability and should be attended to within 24 hours. But they do not rise to the degree that requires either an emergency department or hospitalization. And the other keynote is right at the bottom. Urgent care services are not intended to replace the primary care physician from the standpoint of continuity care. So typically the focus will be on those urgent conditions that develop and that are not expected to develop, that are either beyond the scope of the typical primary care physician's practice or beyond the availability. I'll just segue here a little bit. Holland Hospital is currently in the process of redeveloping its own mission statement. And this is a mission statement that has been cultivated not only in light of some of the things I talked about earlier, the definitions of urgent care medicine, not only in terms of recognizing some of the realities that we'll be facing in the practice of medicine and dispensing health care in this community as a consequence of health care reform. This vision takes that into account, but probably the most important part of it is that there clearly is seen a need to advance a collaborative educational effort between community-based physicians, emergency department physicians, urgent care physicians, and of course patients and the public and the community on how to receive the most appropriate care in the most cost-effective way. And as a vision statement moving forward, there's a lot of excitement and buzz that's being generated about that right now. But the great thing is that this is especially important in a community that offers both services, and in particularly within an institution that offers both services, because many do not. So, a bit of a snapshot regarding the history of urgent care and an industry snapshot. It's been practiced in the United States for over 30 years. And it is a unique medical specialty. There is a specific and extensive medical skill set that's usually necessary, and a fair amount of experience as well. What you may not know is that there is an international presence. That's probably me. Yeah, it is. An international presence regarding urgent care medicine, and usually it is found in most Western communities in which medicine is practiced. And that includes Canada, New Zealand, Australia, and even Israel. So if you think that urgent care is a Holland Hospital phenomena, I got news for you. You know what, Jim? They're Roman. I'm going to kill that. Is that okay? Sorry about that. But following the slide, there are some 9,000 facilities that are open and operating in the United States right now, and the business underpinnings of those are massive. They're owned by physicians, physician groups, hospital systems. About 25% of those that are up and operating are owned by hospital systems. And even private corporations have figured out that this is an amazing way to contribute to the healthcare needs of their community. Many are owned by private corporations. They are found everywhere. They are rural, they are urban, they are suburban, and most have been in operation for greater than 10 to 12 years. About 50% of the centers in the United States have been open that long, and what that means is they are firmly entrenched in the healthcare landscape. They are not going anywhere, and for good reason. There are some 300 to 600 centers opening annually. That is huge for any industry. And that's on pace with, I think, McDonald's. Pretty quick. Gotta love that. And that's fueled by the public's desire for having access to immediate care, no question about it. There's some 20,000 U.S. physicians who specialize or practice urgent care medicine. 91% of them are board certified in one or more disciplines. So a very qualified physician force has dedicated themselves to practicing these services and making them available. And lastly, what's not on this slide is these are very, very busy places. Very busy places. And there are a group of people here who can clearly attest to that. Last year, some 160 million patients were treated in urgent care facilities in the United States. And to give you a little bit of an understanding as to what happens here in Holland, every year about 33,000 patients are cared for at Holland Hospital's urgent care system. And to put that in perspective, that's about 2.5 times the national average per center. So again, Holland Hospital system, very, very important community resource, and the people who are there every day can attest to that. It is very, very important and very, very busy. There's no question about that. This just reminds me to tell you what a typical day is when we open at urgent care. I mean, it definitely can look like that. But what I've been told is that the patient experience is absolutely so phenomenal that patients are willing to climb all over themselves just to get in on time. So I think there's some truth to that, and I think that's pretty fascinating. A bit more about the industry and the background of urgent care. There are several important studies since 2009 which suggest that about 27 to 40% of ED visits are for non-emergent care. We will talk about that in just a minute. Non-emergent care is what urgent care centers specialize in. So you can see that there is a lot of care that's being rendered in the wrong location. We'll talk about that. Subsequently, with those kind of numbers, these make urgent care the most attractive alternative to the emergency department. There's no question about it. What is most interesting about urgent care as an industry, it is already poised to respond to the realities of the Patient and Protection and Affordable Care Act. Its expanse, its availability, and the broad scope of care that goes on there actually will be part of the solution going forward. What we envision happening, just so that you know, is as healthcare reform takes shape, family physicians and continuity physicians are going to be spending a lot of time concentrating on developing what are called medical homes for the patients that they take care of, attending to their ongoing, chronic, and continuous medical needs. What that leaves is not only a large population of people, but many, many conditions and clinical presentations that someone else is going to need to take care of. And the important thing is that urgent care systems in this country are already up and running and are already poised to receive that patient base and are specialists at taking care of unanticipated and unplanned illness and injury. So what we see going forward, what the trend will be going forward, is that your family physician, your continuity physician gets a chance to focus on what they do best, and the industry of urgent care medicine gets a chance to complement that, a shared responsibility, if you will, by concentrating on what they do best. So there's no question that that is going to be the most viable path forward. And what is interesting, I take you back to that vision statement that Holland Hospital Urgent Care Center has for moving forward in the community. The underpinnings of that are already percolating. This is getting real exciting because it suggests that the organization is well ahead of the curve in putting this together. So that couldn't be more exciting. The services that were provided in urgent care centers in the United States in 2008, that's where this statistic comes from, were $13 billion. There are already those who suggest that by the end of 2013, it may be at least 16% more than that. And what that suggests is that there is a growing public recognition for what urgent care systems can do and how they can complement what's going on in the community in terms of healthcare choices. And it also is suggested that there is an absolute huge access benefit. When you can find some place to go when you need to, you better believe people will come. They say you build them and people will come. No question about it. That's not just McDonald's. I've talked about them again tonight. You hungry yet? No. Okay. The industry is certainly growing and healthy. As I said before, 160 million visits per year, and that is pretty massive. There's no question about that. So whatever your view of U.S. healthcare will be, whether it's a good one or a bad one, or whether you're afraid of it or whether you are excited about it, as healthcare reform takes place, all of our data tells us that urgent care systems will be a vital part of the solution, hands down. There's no question about that. So you should be excited that you have a system that's already up and running in Holland, Michigan to serve your needs. There are many communities who are looking to put in place what's already here. So I couldn't be more excited about that. More characteristics of urgent care practices very quickly. They are uniformly outpatient. Their focus is on new, onset, episodic, acute, and non-life-threatening illness. The practice and the care that's rendered crosses all medical specialties. These tend to be lower acuity injuries and illnesses. And one of the things that we are most grateful for is that there are national best practice accreditation and standards which have been self-imposed on the industry, which are now coming to the forefront, with the quality of care probably being the forerunner and the benchmark for how urgent care as an industry is defining itself. These are best practice accreditations and standards that are on par with what emergency departments and hospitals currently have to contend with by their regulatory agencies. So it's great to see that an industry has already gotten out in front of being regulated and has decided to be all that it can be. Very exciting. Urgent care practices serve patients of all ages on a first-come, first-served basis. They offer an array of office-based laboratory and x-ray services, not to the extent, however, that emergency departments do or hospitals do. We'll touch on that in just a bit. Many are equipped to administer intravenous fluids and medications by various routes. Many do have real-time language interpretation services to attend to the cultural needs of some of their patients and clientele. And typically the most successful staffing models include not only very qualified physicians who are knowledgeable of the discipline, but an array of support staff which include mid-level practitioners, nurse practitioners, physician's assistants licensed in the state and clearly trained in urgent care principles. And very important adjunct is the qualified nursing staff, x-ray tech staff, unit tech and support staff who round out what I call the frontline warriors who provide urgent care services every day. So the most successful practices clearly recognize the very important benefit of all of those unique roles as they put together a staffing model that works for everybody. Urgent care centers often have to be capable of preparing and referring patients who are acutely ill to the next level of care, so they should be very well versed in accomplishing that. And one of the virtues of urgent care practice is that its administrative and cost structure tends to be less cumbersome. So for most people who are typically tend to be confused about all that insurance does and doesn't cover, urgent care can make that very simple. So these are take-home points. This is where the quiz is coming from. What urgent care is not. Okay? It is not a replacement for continuity primary care. It's not intended to be your family physician. We were just talking earlier about sometimes that can happen when you do what you do very well. But that is not what the intent of urgent care medicine is. Urgent care centers are not mini EDs in smaller buildings with shorter wait times. That's not what they are. Okay? They are not for advanced care. If your healthcare need requires advanced diagnostics, advanced therapies and technologies, high-tech provisions for care, and big-time consultants and specialists, you're not going to find those people, as necessary as they are for some people's care. You're not going to find those in the urgent care centers. And the other thing is they are not the location of choice for true medical emergencies, labor and acute obstetric needs, and for acute psychiatric care. So, and those of you who spend time in this facility know exactly what that means. Okay. We'll segue talking about emergencies into emergency medicine as a discipline in the emergency department. Emergency medicine has been broken down in terms of definition into two main parts. There's what's called pre-institutional emergency care, and then there is institutional care. Pre-institutional emergency care really is the emergency service care that's provided at the scene when an acute illness or injury is recognized, and usually it is provided by first responders, EMS personnel, who not only are caring for people at the scene, but that care also includes their transport to the next level of care, typically an emergency department or a major medical center. But the area that we're going to focus on is the institutional care part of this, and that's the hospital emergency department care. So that's the second half of the focus this evening as we compare these two. Emergency medicine, its history in a snapshot, it's been a specialty in the United States since 1979. There are some 40,000 physicians who practice emergency medicine almost full-time. Many are board certified. And emergency department medicine, that is medicine practiced 24/7 at a hospital or major medical center, actually had its origins in two very important plans, one of which originated just northeast of here in Pontiac, Michigan. And the plans that were adopted, one was the Pontiac Mission Plan, the other was the Alexandria, Virginia Plan. Back in the 1960s, those two communities and the physicians in those communities recognized that there was a huge need for being able to provide care to patients who did not have an appointment, did not have a family physician, and whose injury or illness was clearly something that was unanticipated. What those physicians in those areas did almost contemporaneously at about the same time is that many of them left their primary care practices, they banded together, and they decided to provide that 24/7, 365 care in the beginning, often in the basement of these hospitals. And those are the very humble origins of what we now know today as huge megaplex tertiary care emergency departments. And if you've not been to one, my guess is you've probably seen a rendition of one in the current media and films and what have you. There's no question about it. Very humble beginnings as a philosophy and as a practice system. But today, very big, 136 or more million visits per year. And presently, there are about 3,900 United States hospital EDs. The thing that's concerning about healthcare in the future is that that number is dropping off quickly. When I talked about providing care in a setting where we have diminishing logistics and diminishing institutional capacity, emergency departments are closing faster than they ever have before in the United States healthcare system. There are good reasons for that. That's not the topic for tonight, but it's important that you know. Very important industry, but nonetheless one that's being challenged on all fronts. So, more about emergency medicine as a discipline. There are 20 million patients that arrive in emergency departments every year by ambulance. 2/3 of U.S. emergency departments are classified as safety net hospitals. They are operating at or over capacity, and most recently the average visit time has crested about 4 hours. Part of the reason for that is back to my other statistic, 27 to 40% of what's going on there is non-emergent care that probably shouldn't have been in an emergency department. And so the point is that emergency departments and their physicians are having to provide non-emergent care or primary care for patients who don't have a primary care provider or don't choose to use one. Emergency departments comprise 45% of all hospital admissions, and the fastest growing demographic, the fastest growing patient base who is finding themselves in the emergency room are the elderly. You can define that however you want. 50 is not that age. But anyway, one thing you should take home is that emergency departments are high cost, low efficiency facilities for non-emergent care. We'll talk about that more. Characteristics continued. They typically are part of hospitals or major medical centers. They specialize in the acute care of the most critically ill and injured patients of all ages. And as we talked about before, they are 24/7, 365-day-a-year operations. They never close. They are the recipients. They receive ambulance or EMS transported patients. They usually have access to state-of-the-art technologies in terms of providing service. Many of them have a full range of specialists on staff, and all emergency rooms are not created equal, depending on their unique accreditations for the services that they give and the level for which they have been designated, anything from 1 through 5. Emergency departments often have specialists available to complement the care that's given by emergency department physicians, and there's no question it is the gateway for most unscheduled hospital admissions. So the take-home point here is that despite their 24-hour access, their great technologies, there is increasing recognition as we move forward with healthcare reform that these high-cost, low-efficiency venues for non-emergency care will be forcing some changes. So no question about it. What the ED is not. Much like urgent care, it is not a replacement for continuity primary care in the community with your physician. It is not the place for non-emergent care. And contrary to popular opinion, though there has been a lot done to try to increase turnaround times in emergency departments, it will not be the place for shorter wait times. When we consider the fact that these places are designed to address the needs of the most critically ill and injured persons, people who are presenting with conditions like heart attacks and strokes, severe trauma, major infections, organ failure, active labor and pregnancy complications, psychiatric emergencies, poisonings, very sick children, very sick babies and infants, just to name a few, you have to anticipate that if you present to an emergency department for non-urgent care, you will likely be deprioritized. Now understand, that doesn't mean you're any less important, but because their resources are charged with caring for the most critically ill patients, they'll get to you. But they're going to have to get to you a little bit later. The other thing is that you can anticipate that as we see sicker patients and patients in the emergency department who will probably be finding their way into the hospital, the wait times in emergency rooms, as great a job as they do, will probably only increase. So if you're there for a condition that they don't specialize in, and if you're there for a condition that falls lower on their radar, you have to anticipate it may be a more difficult time for you. And again, this is where we see urgent care medicine picking up the slack and making sure that people who have appropriate conditions can actually get the care they need in the right time. Okay? So, as we've covered both disciplines, a few of the similarities so that there's no confusion before we leave. Urgent care systems and emergency departments both offer extended hours. They evaluate and treat patients of all ages, but to various levels. They have extensively trained providers and staff. They care for unscheduled, acute, episodic illness and injury, but to different degrees. They have a range of diagnostic testing and medical therapies, but to different degrees. But both are quite capable of coordinating your care in real time, that is, communicating with family physicians, other institutions, specialists, what have you, to make sure that the care that's necessary after an emergency department or urgent care trip results in follow-up care. But the take-home point from all this is that, as outlined, though they have similarities, they are still very, very different environments. They each have their own mission, their own capabilities, they have their own limits, and they have their own purpose. And just a quick note aside, I'm not sure if you're looking at these pretty closely, but are there any photography buffs in the audience? That's the only thing I did want to make sure of. Okay, this will be a fun question then. Real quick, in the interest of time, can anyone tell me what this ED picture and this urgent care picture have in common? No? That's a good guess, though. I'll save the suspense. Much like emergency departments and urgent care medicine and urgent care centers, they have some things in common. And there are only two things that these pictures have in common. They were taken with the same camera, and they were taken on the same planet. That's about it. So, anyway, here's a nutshell. This is what we really want to crack open tonight. When unplanned injury and illness happens, where do we go? How do you choose between the urgent care system and the emergency department system? And so, now that you all have your PhDs in urgent care and emergency department philosophy, this should be pretty easy for you. but I'll certainly give you a few tips so you can navigate that process. Okay? Choosing between urgent care and the emergency department really requires an action plan. And that action plan mandates that you understand your options and that you ask the right questions. When unplanned illness or injury develops, believe it or not, as healthcare systems evolve and your responsibilities in a healthcare system continue to evolve, more of this decision making is going to fall on you. So it behooves you to get acquainted with knowing how to make decisions and knowing what things should be part of that calculus. One of the first things that I want to introduce you to is something interesting under the new Affordable Care Act, or Obamacare, whatever you call it. It's a standard called the Prudent Layperson Standard. And under the new law, what this demands is that healthcare plans have to now define what a medical emergency is as a condition of paying for it. Okay? And they define an emergency condition as an acute condition of significant enough severity that a person who possesses average knowledge of health and medicine would be able to conclude that the absence of immediate emergency department services or attention would most likely result in immediate compromise of that individual or an unborn child, putting them in serious jeopardy, leave that individual with serious impairment of bodily functions, or result in serious dysfunction of an organ or body part. Now, I share that definition with you because inherent in that definition is that you, as healthcare consumers and lay public, are expected now to begin to understand what that means. So, when we move forward, please understand, that may seem like an ominous task for you. No one is standing back asking you to be your own doctor and figure out what's going on. But it behooves you to get acquainted with what you're going to find in the near future in terms of what your responsibility is for coordinating your own care. That's going to be very important. What we now know with some preliminary data, as this has already been looked at, is that as far as this standard is concerned, average patients are very capable of figuring out whether what's going on with them falls within that definition. So we can talk about that another time. I don't want to spend too much time on it. Many emergency department industry analysts and many emergency department organizations basically consider people in this category people who need to have urgent care, or immediate care within 1 minute to 2 hours where something bad happens. So the second question that you want to begin to ask is the care that you need, or is the condition that you have, is it urgent or is it emergent? Okay? Let me just say something to you right quick so that there is no confusion. If you are in a situation where you fear that the condition that you're dealing with is very, very serious or potentially very serious, though this calculus will be helpful for you, and we'll touch on how to summarize that in a little bit, probably the most important thing that you want to know is that if you have a question, you should present to an emergency department or call 911 to make sure that you're not having a serious problem and you're not getting it addressed. I think last month, Dr. Katari from the emergency department talked about the evolution of stroke care and what's happening here in Holland, Michigan. And I'm pretty sure he touched on some of the signs and symptoms that are a prelude to that kind of a disease process. And so my point is that the take-home point here is that if you know that's what's going on with you, you want to get to an emergency department or call 911. If you're not sure if that's what's going on with you, no one's expecting that you're going to have this layperson standard on the refrigerator and that when you cut yourself up or fall down the stairs that you're going to pull out that standard and say, okay, yeah, Rhonda, I guess this is us. No, it's not going to work like that, okay? So I don't want to leave you confused. I don't want to leave you misinformed, but I want to leave you enlightened about what's coming, okay? The third part of how you can make those choices is, as a community and as someone who lives in the community, you need to know your treatment options. Basically, you need to know what services are available in your area, your neck of the woods, and you need to know what their capacity is, what it is that they can actually take care of, and what are the types of things that they are more likely to be able to address. This is actually a slide that is certainly not exhaustive, but it has a couple of different columns and a couple of different categories. I'll summarize this and say that you see across the top the options that typically are in most communities. There's a phenomenon called retail health clinic that is on the far left. It is a thought process that may not gain as much support in that there are not physicians who staff those facilities, so it may not necessarily be a valuable option for most. But certainly in this community, you have your doctor's office, you have urgent care centers, and you have the emergency department. What you see in the on the left side, the types of conditions that can present to all of these places. And just so you know, these are the top 30 or so conditions that bring people to immediate care or bring people in for unanticipated illness. What I'll share with you is that if you walk about 2/3 of the way up, what you can see is that there are a number of different conditions that can be cared for in many different places. But there is clearly a group of conditions that should only be cared for in an emergency department. And so the point tonight is that though certain types of lower level, low acuity care can be managed and can be offered in several different settings, including urgent care, it behooves you to understand that category of conditions that should never present to an urgent care center, but are only best taken care of in the emergency department. I'll cover some of those, and there's some brochures that are certainly available for you to actually summarize that you can get from the marketing department. But just as in this slide, the types of things that should go to an emergency department: persistent abdominal pain, chest pain or pressure, severe shortness of breath or inability to breathe, uncontrollable bleeding and intense pain, major facial lacerations, head injuries, or obviously broken bones or dislocations. Lacerations that could be limb-threatening, amputations or partial amputations, sudden severe headaches, poisonings, suspected overdose, seizure and loss of consciousness, numbness, paralysis of the face, arm, or leg. Dr. Katari touched on some of that last month. Sudden slurred speech, visual changes or weakness, severe reactions to bites, food, or medications, major burns, chest pain that could be or is suggestive of heart disease or a heart attack or an irregular heartbeat, and of course, as we talked about, obstetric care, acute labor, injuries in the context of pregnancy, and then acute psychiatric emergencies. These are the things that should only present to an emergency department. They are equipped and ready to take care of those things. On the other hand, as you can see, 2/3 of the other conditions that form the lower third or lower 2/3 of that slide, the types of things that are best managed in an urgent care setting, these are coughs, colds, flu, abrasions, cuts, bruises, minor lacerations that may need repair, mild to moderate allergic reactions, insect bites, sprains, strains, minor or modest fractures or not obvious fractures, minor burns, wounds, abscesses, minor eye injuries, fevers, vomiting, diarrhea, various infections of the upper respiratory tract, eyes or skin, urinary tract infections, concerns about sexually transmitted disease care, and other non-life-threatening illnesses and injury that you cannot get in for or you cannot get in with your family physician about. So there's a lot on that slide. I don't expect you to remember it. It's not on the quiz, but hopefully that gives you a snapshot that there is overlap in terms of where you can get care, but there are clearly some things that this slide demarcates that should only be seen in emergency department. Okay? And let me get done with the rest of this. Continuing to choose between urgent care and the emergency department, one of the things that's important to do is to consider the timing of your care. Not only is the timing of your care important, but how much time will it take to get definitive care? Is the care immediate or can it wait? Is that care necessary after regular office hours? Okay? Based on what you now know, if you present to an emergency department for non-emergent care, you can expect to be a little less of a priority. You can expect a delay in care and possibly have to wait longer. But by the same token, if you present to an urgent care center with a life or limb-threatening injury or illness, equally you can expect to have a delay in getting definitive care. It's not that your need wouldn't be addressed up front, but the problem is that you will likely require referral or transport to an emergency department or hospital, and subsequently you've experienced a delay in care. The bottom line here is that showing up in the wrong place at the wrong time with the wrong condition could be a lose-lose situation for everybody involved. Okay? So how do you keep that from happening? You get some guidance. Right now, most insurers, most hospital systems offer 24-hour helplines to help you navigate where you should go and what you should do. There are nurse advice lines that most healthcare centers and some insurers actually have, where you're speaking to a nurse who not only can kind of triage your situation but give you some advice as to what would be the proper venue for you to go. Most insurance plans and documents are now including discussions about emergency care and urgent care. And in fact, some of you may have noticed that there are now separate co-pays and financial obligations for you if you present to one versus the other. And as a last resort, if you are still in question about where you might want to go and how to think about that, you can certainly call your local emergency department or urgent care center, but please understand their time and attention is really focused on the people who are right in front of them. And so they are not likely to give you a lot of medical advice, but they certainly can be helpful in directing you to which venue might best accommodate you in terms of what your needs are going to be. Okay? And finally, some of the benefits of making the right choice between urgent care and the emergency department. When you do that, you get a chance to receive tailored medical care and quality care that's specific to your needs. You maximize time and money savings. You avoid insurance penalties and sometimes deductibles. Some plans may levy penalties if you happen to receive non-emergent care in an emergency department setting. So it's important where you show up and why. Okay? You get a chance to make the best use of your copay, and probably most importantly is that you get your care expectations met. One of the most frustrating things that I and my staff deal with every day are people who are in the throes of an acute medical condition or an acute condition or acute illness, and they're concerned about what it may mean for them, but they're struggling with the fact that once they've arrived, they figured out that they're in the wrong place. And it is one of the most frustrating things as a patient that anybody could ever experience, but my point to you is that it is not necessary. Okay? In summary, and these are the take-home points, hospital emergency departments are high cost and low efficient for the provision of non-emergent care. They are, however, the location of choice for true medical emergencies, obstetric emergencies, and acute psychiatric care. Urgent care facilities, on the other hand, tend to be lower cost. They are clearly geared toward high-efficient non-emergent care, and they are not the suitable place to be for true medical emergencies. Again, their focus is an option when your family physician is not available or for conditions that are outside of the scope of your family physician or your private physician's practice or availability. And one of the last slides here, this is a summary of your Empowered to Choose action plan. These have been named Dr. Mott's 7 Habits of Highly Effective Patients. And I think that that's the case. In summary, you need to know your options. Where do you get care and what's available in your community? 2, you need to know what a true emergency really is and isn't. Number 3, you want to do some preparation in advance. Struggling with some of this thought process is not the place you want to be when something unanticipated happens. But now with information in hand, you can begin to prepare in advance as to what you might do and how you might do it if you're faced with a situation like that. Number 4, you want to consider the severity of your illness. 5, you want to consider the time it will take to get definitive care. And 6, you want to research the impact of your healthcare choices. That's going to be something that is expected of all of us in the near future. And 7 is to keep attending Holland Hospital's Physician Lecture Series. No question about it. There is more to come. And I'm pretty much done. So my best to you. I hope you've enjoyed the evening. I've had a lot of fun. And I think we have a little bit of time for some questions and answers in just a minute. But I think Ronnie might have something for me, not just yet. Okay. Okay. Well, I think we have a few minutes left. If there are some specific questions or answers, I'll try to get to a few at least in the interest of time. Joe, I'll try to do what you told me to do. Okay? Any questions that I can touch on right quick? Ma'am, right here, ma'am. There are times where, and again, I offer you a calculus that works in many different settings, and there's some generalities here that I think I definitely want you to understand. Your unique specific needs, though, may be different from the person sitting next to you. Depending on what you really had, what your background is, what your other medical conditions may be, things as simple as what medicines you're taking, what reactions you might have, or what may be other injuries that you don't even recognize at the time that you present. A lot of that may not be available for you at the time you're coming in. You may not know it or understand it, but sometimes there's a calculus made when you present to urgent care or the emergency department where the best care and all of the eventualities that come with that might be best handled in a different setting. So everyone would apologize for any inconvenience, but I think the important thing is that if there was a concern that your care should have been rendered in one place or another, that is ultimately going to be something that the treating physicians and the staff in one location or another are best capable of giving you some insight on. So I'm not quite sure what it is. Yes, absolutely. You talked about North Side. That's one of the confusions that we have in the community. There are a lot of people who think that North Side is the North Emergency Department at Holland Hospital. Forgive us if our marketing effort at this point has not clarified that for you. But hopefully there'll be a little bit more on this in the future. And my hope is that, see, tonight makes a big difference for you. You just proved that being in the right place, getting the right information, you'll never make that mistake again, right? Got that. Got that. There was another question, I'm sorry, sir, in the corner. What you were saying was is that there are differences in terms of managing acute psychiatric illness or care in a community, and urgent care is typically not equipped with the appropriate personnel, the appropriate safeguards to manage acute psychiatric emergencies. There's no question about that. In addition to that, emergency departments, which have, again, as we outlined, a fund of specialists and resources available, access to other community resources, 24/7 availability, and of course some of the things you talked about. Safety for both patients and families who happen to be attending to that person who is ill, but also the safety and the best locale for the staff who are tending to such an acute emergency. All of that is part of the calculus in terms of whether or not a patient is best cared for in one venue or another. I'll just say, to complement the rest of that question, that mental health services are one of the few things that, going forward, the Affordable Care Act is going to have to address in a very serious way. There are huge gaps in mental health services and what seem to be an ever-increasing demand for them. So we anticipate, and that question is a very it goes deeper than you might even imagine, to educate people in terms of where they really need to go. What we will anticipate is that more and more acute psychiatric emergent care will be in the emergency department, but emergency departments are and probably are going to be beginning to develop a safety net of other resources on an outpatient basis who they coordinate with to get people who have a certain level of care to the right place. That probably won't be urgent care, but mental health and its evolution in the next 10 years is going to be amazing. So anyway, one last question maybe if we might. I think I know you. Great question. Great question. Retail clinics are a rather new phenomenon. I think they have been around probably for about 6 or 8 years. And retail clinics happen to be small clinical locations, often owned and operated by non-medical entities, the largest of which are affiliated with Walgreens, which is a national pharmacy. Walmart has moved into that business, and CVS. And retail clinics are typically staffed with a non-physician provider, and their focus is the least level of acute care. Some vaccinations, a few medical conditions, and very, very limited diagnostic services. There was a hope that that subset of patients would not necessarily need to go to an urgent care center and subsequently could enjoy a reasonable level of care at an even lower price. The problem that retail clinics are facing is that they're having a lot of difficulty defining themselves and defining the scope of their care. Part of that is because there are no physicians present in those locations. When there are physicians present in a location, you can be absolutely sure that there's a clear definition as to what can be managed in that setting. And so retail clinics, for whatever they're worth, they've been here. There may be a place for them in the future in some way, but they are not likely to become popular. But as to other clinics and other resources, many communities definitely have faith-based clinics. They have community clinics that are part of community resources, and organizations band together to provide that kind of service. They're not necessarily geared toward the same scope of care that urgent care is, but they tend to be outlets for ongoing continuity primary care. City on a Hill that we talked about, and a couple others that are here in the area. They are still geared toward the provision of that ongoing continuity primary care, much like the personal physician or private physician's office. So they are necessary. My hope is that they will get the attention that they need in healthcare reform. Fortunately, they're part of this community. As far as I'm concerned, they're heaven sent. They're a place where people need to be able to go when they don't have resources. But our hope is to be able to communicate both with them, urgent care, the emergency department, and the medical community in general about how to coordinate services for all. So, great question, and that's going to be something that we're still working on. I know you. This is actually, I don't know if anybody knows, this is the reigning 2013 Mrs. America, who is actually raising her hand. I'm actually married to her, so she gets a chance to answer a question. Yes? Yes, currently there is one urgent care that functions in the capacity that I'm sharing with you now. There is some thought on the horizon that as our needs continue to evolve and urgent care takes its rightful place and its ability to provide the right kind of services to the right population of people, that could continue to grow. My hope is that if this community and the Lakeshore recognize as a continuing need, that Holland Hospital will take the lead in that. So to answer your question, there is one fully established, up and running, very busy, qualified place to get the kind of non-emergent care that we talked about, and maybe some more on the horizon. We'll see. Good question. I agree with you, and there's no question about it. And I think that as we become clearly a group of everyday folks who realize that we're going to have to take more responsibility for our own health care, I think that it's already clear that those kinds of things are being set up, and the people who staff those facilities and the people who commit themselves to providing that service go a long way to helping you and I make the right decisions. There's financial impact, there's immediate healthcare outcome impact, and there's community impact. And to have those resources, and they're coming in from every level. You have hospital systems, you have private corporations, you have physicians' practices and groups, you have insurers, all of whom have realized that the cornerstone of moving forward is going to be education, education, education. Did I say physician lecture series? Education, education, what have you. So, thank you. Definite insight, definite necessary. I'll take one question, and then I'm going to check my pants, and then I think we'll get out of here. Is that okay? Why did I put the alligator picture up there? I borrowed that picture from somebody. Do you know who that might be? Yeah. That's my little photographer right there. But that alligator picture kind of represents how those of us who really care about what we do recognize how important it is, and we recognize the need that we fulfill. And I think it's interesting. People will show up when they are in need. And man, do they show up fast, and do they show up in abundance. And for me, I think that is kind of a fun way of taking your work and incorporating it into mine. So anyway, thank you. Appreciate your time and attention.
You want to kick somebody out of here?